I'm Zoe Richmond. I'm an optometrist and I'm the Clinical Director for the NOC Support Unit. Just need to say that this session is sponsored by Optos, so thank you to Optos for their sponsorship. In this clinical pathway update, we'll be looking back to 2019 and the NOC work pathway and workshops that we delivered. We'll consider what we have achieved in 2020, which may not be quite what we expected to achieve in 2020. We'll consider CUES, the new COVID-19 urgent eye care pathway, and what that means for us all. We'll briefly discuss the National Outpatient Transformation Programme and how this all fits together. We'll also have a panel discussion, and I'll be inviting team members to join me in that to take some of your questions. And at the end of the session, I'll be handing over to Richard Whittington, who'll close the session and perhaps just briefly talk about the changing commissioning landscape and what that means for us all. Throughout the session, we will be inviting your questions. So if you look at your screen, you should be able to see a Q&A box, and I would like to invite you all to submit your questions as we go throughout the session. And with that, I'm just going to invite Tom to put his screen on and introduce himself.
Good evening. Hello. My name is Tom Mackley. I'm an optometrist at NOC and an optometrist by background. We'll start by talking about the NOC 2019. Here's a slide with showing the sessions that Zoe and I did about pathway development. It seems like an awfully long time ago now. Awful lot's happened since then, but hopefully some of you remember. I think I can see some names I recognise in the attendee list there. And what we did, we asked you for ideas about potential pathways that we could work up. We asked you to be unconstrained in your thinking, to give us some inspiration, to think about your ambitions, your ideas, blue sky thinking, for want of a better phrase. And we didn't want to go over what were already published pathways, but think about new opportunities. And we held 2 sessions, and with several groups working in each session, and they were really great sessions. We got valuable feedback from all of them, and we took those ideas away and to work through. First of all, we did, if we could go to the next slide, Zoe, please. We asked people to just sort of quick fire ideas of what we could pursue, and we filled some flip charts. There's my dreadful writing on the left there, and we just put up all the ideas we could, and we sort of shouted snap whenever we got the same idea twice from different groups. So that's what the snap thing in the top right hand corner is. And then we chose some for those groups to go back and to go over to try and develop further, to think through the ideas and give us a bit more detail. And we got a lot of material from that process too. We then transferred this information onto spreadsheets, so a little bit easier to read than my scrawl. And you can see on that list there what we came up with. The yellow boxes on the right hand side, those are the ones where we got a snap, where we got the same idea coming through twice. And the numbers are from a process that came about later, where we took all this data down to the LOCSU office and got the team together and examined the detail of what had been produced. We looked through the suggestions, looked at what you'd said, and started to discuss what was deliverable. What could we use this information for? So we had to try and prioritize what was quite a long list. We were unlikely to be able to deliver all of that lot in one go. So we had to see where we could get some wins. And you can see the numbers on the right hand side there. Those are the votes, the cumulative votes from the LOCSU optical lead team about what we thought we should work on first. Some ideas did have to be sort of by the necessity parked, just because they weren't deliverable or in our gift, if you like. So things like the driving vision is really something that's going to be led by Department of Transport or DVLA. It's a good ambition. It's a big ambition. It's something we can lobby for and talk about. But until those very influential bodies decide they want to do something with it, we're probably not going to move that forward very quickly. And myopia management was another one where the current evidence base doesn't quite support the interventions that we may like to put into a pathway. It's definitely coming. We're aware that evidence base is growing. We're aware it's one for the future. And this is definitely not put to the side, but it's it's one we need to bide our time a little bit on before we can deliver something with a strong evidence base. And some needed some background work. So if you look at, for example, YAG laser and AMD injections, they were exciting ideas, but we needed to really look at the regulatory implications, the training requirements, what costs might be involved, and to see if it was viable in a primary care setting. And others are a little more complex than they might first appear. So keratoconus, specialist contact lens fitting, definitely one we think is of great potential. But there are various solutions in place in different localities. We'd want to distill the best of those, identify best practice, and produce something that didn't disrupt services that are already in place. So we were working through the ideas in this way. And blind and partially sight registration is another one. I received a lot of support for this idea, but it will require some partnership working with people like the Royal College. And so the certification process isn't a simple thing to get involved in and change in a short space of time. So, and others, certainly not forgotten or put aside, but some will take longer to work through and to develop than others. Dry eye management was certainly one that we recognised as an opportunity. Healthy living optical practice, if you think back 12 months, was very much something everyone was talking about at that time. And then our runner-up there, the macular monitoring and independent prescribing pathways, didn't get as many votes, but we sort of picked those out as runner-up ideas. These were all being worked on, discussed, and developed when COVID hit. And COVID did disrupt our works to some degree. It didn't stop it, we kept on, and progress has still been made. And that's what Zoe's going to talk about next in the next slide.
Thank you, Tom. So what progress have we made in 2020? Well, we started in February by developing a healthy living optical practice framework. As Tom suggests, there was lots of appetite from the NOC session last year, and certainly support from the LOCSU team too, for LOCSU to develop a simple framework for LOCs to use to invite a discussion at a local level. As the name suggests, the Healthy Living Optical Practice Framework focuses on improving population health and well-being. It's not particularly an eye health pathway, and I don't either believe it is a standalone service. Rather, it needs to be added on, if you like, when you've got a number of commissioned pathways locally. There are two levels within the Healthy Living Optical Practice Framework. Level 1 is a brief intervention, so simple questioning, signposting to information that you might already have in optical practice. And certainly before COVID-19, as part of our sight testing routine, we might ask somebody, if they've told us that they're a smoker, we might have a conversation with them and take a little bit of time out to talk to them about the impact of smoking on their ocular health. And that is level 1, Healthy Living Optical Practice. Level 2 would be a little bit more involved. This would be delivering an intervention within optical practice, and it would need to be commissioned, and then there would need to be an appropriate funding stream made available. And what's delivered within level 2 Healthy Living Optical Practice really very largely depends on the local priority and the local population need. So I'd invite you to take that framework along next time your LOC is invited to a meeting with the primary care network, because it's something that you might want to invite a discussion around. The next pathway that we finalised, although it wasn't published immediately, pardon me, the brachyopathy one was published in March, and we revisited it in May to bring into it some COVID-19 urgent eye care principles, the principles of triaging out to another practice and ophthalmology advice and guidance. So the macular filtering and monitoring pathway was published in March, and it delivered an end-to-end pathway of integrated care. So it offers a greater clinical workup at the front end of the pathway, supporting your referral decision-making, but also offers a monitoring service for those patients that have had their treatment and require long-term monitoring. And obviously with this pathway, patients might present in a number of ways. They might present during a sight test or minor eye condition service, or within the Q service. There's a lot of overlap between these pathways, but I do think it was worthwhile having a standalone pathway for this particular area of care. And that takes us on to April and the response to COVID-19, the COVID-19 Urgent Eye Care Service. And I think within this pathway, we've demonstrated our commitment to deliver more services for independent prescribing optometrists. And that is one of the asks from last year's NOC. And we'll continue to integrate optometrists with higher qualifications into each of our care pathways where it's possible. CUES was developed at pace. It was co-produced by LOCSU, working alongside the Clinical Council for Eye Health Commissioning, and facilitated by NHS England. And it has clinical endorsement by the College of Optometrists and Royal College of Ophthalmologists. Now, this is a first for us, and it's a really a pivotal place for pathway redesign, certainly. So CUES recognises and makes best use of the whole optometry workforce and the optical practice capability. Within CUES, we encourage networking across optical practices and a closer working relationship between all clinicians, so the clinicians within optical practice and those within the hospital eye service teams as well. I'm going to discuss the outcomes of CUES a little bit more later in the session. So looking at the children's services, for a long time now, we've had a diagnostic pathway following for children that have had vision screening in school. We've refreshed that pathway, but also built in a more integrated service model. And this allows for children already known to the hospital eye service to be transferred out into the primary eye care service to receive some or all of their care. And although we maybe don't think about the children who fail vision screening as being a priority at the moment necessarily, we all know that the majority of children that fail vision screening actually have perfectly normal vision or simply need a refractive correction. But also vision screening teams are not managing to get into schools at the minute. So I'd urge you all as LOCs to have conversations with your local system leaders to understand what's happening locally and to make sure these children are seen at the earliest opportunity. And the last pathway that we published more recently was a refreshed route pathway again for people with learning disabilities. We worked with WOPEC, Seeability and MenCap, and we've certainly made some considerable improvements to this pathway. So it now includes all children with learning disabilities and also people who would have traditionally had their care delivered within the hospital eye service, largely because there was no appropriate service within primary care, and they're now able to be transferred into the primary care service. And the teams within primary care are working very closely with the expert teams within the hospital. The pathway also encourages a managed transition from the new National Special Schools programme that's just beginning to be piloted into the locally commissioned primary care service. So with that, Tom, what should 2021 bring?
Well, yes, as you say, another year has passed. What should we be focusing on next? We're going to give you a poll now, so we'll pop the list up. Please pick your top 3. Are they coming up? Yes, they are. So dry eye disease management, the diagnosis and management of dry eye, inspired by Jews too. Keep these people out of hospital, manage them in the community, and it's obvious really. Low vision support. So it's a service really for an underserved group in many ways. It could be LVAs, it could be more, and it could possibly include remote certification of partially sighted and severely visually impaired people. Falls and frailty, so may sit alongside or within healthy living type arrangements, but I have come across interest in this from PCNs in some areas. Nevus pigmented lesion monitoring, there's again some interest in this in some areas already. It's an obvious one. We can do the imaging, and we can use technology to share those images and share OCT scans with our ophthalmology colleagues. Specialist contact lenses, keratoconus, but other things, pellucid marginal degeneration, etc., using specialist skills to their best. And YAG SLT laser, obviously a complex area and possibly a niche, and certainly a lot of upskilling involved, but a huge opportunity, a very ambitious one, I think, and well worth considering. So I think we are at 87%. Oh, hang on, we've got 80% of people have voted, 45.
It's moving very quite fast now, up to 90%.
I looked up and thought, wow, that's amazing.
Should we call it there and see what the results bring?
I don't think it's going to change much, is it?
Right, so we've got a clear winner there, haven't we, Tom? With dry eye disease monitoring and management, and that's quite exciting for me actually, because I do have a draft pathway. I've worked with a couple of LOCs that have a pathway ready. We were going to pilot it at the beginning of this year, and that's been suspended obviously because of COVID-19. But that's a clear winner. So that gives me a clear steer for early next year to perhaps invite a little bit of a workshop with those interested people to look at that pathway and see how it can be managed in primary care.
It's good to have a mandate, isn't it? Because we sometimes think we know what everyone wants, but it's good to have it confirmed. And this has been something we've talked about a bit in the past, and it's definitely deliverable.
And the low vision one, although we do know that it's incredibly ambitious, but I personally believe that certainly with COVID-19 we ought to be looking to deliver certification for low vision at a local level. Why can't we do that? Why should those patients have to make a trip to the hospital eye service to receive their certification so that it can be registered? I think there's, we are working in a much more remote way than there must be a way that can be delivered differently. Again, as you said, not an easy win, but something that we've now got the mandate to move forward with and explore as LOCSO. So
we're already building some better relationships with secondary care such that we can have the conversation based upon relationships that are already going in the right direction.
Certainly worthwhile. Worthwhile. So thank you to everybody for putting their thoughts forward, and we'll move on to the next slide. So we're moving back onto queues now, and I'm going to play you a video. And this is from a handful of practitioners who have been involved in queues delivery. Let's hear what they have to say.
Queues is the first commissioned service to go live within Hillingdon, and so it represents a major advancement in community eye care for our practices and primary care optometrists. With the inclusion of IP provision and OCT, Queues allows us to manage more severe eye conditions, broadening the scope of eye care for our communities. That primary care optometry has an integral and important role in reducing the burden on an already stretched secondary care.
As a previous METS practitioner, we got used to in our practice only being able to see patients within a certain CCG. The nice thing about queues is that with all our surrounding CCGs having taken part, now it's not the patient's postcode that depends on what care we give them. It's been really useful with the Opera platform to be able to look up a patient, check that their CCG covers the queues, and then get all their details on Opera. With given consent, being able to access the shared care record and be able to view their medication when the patient usually doesn't know what they're taking has been really helpful.
First patient I saw who was self-referred, but soon we were seeing patients being referred by the GP, also by 111, along with pharmacy, and even patients who just rang up for some advice. Local pharmacists have been quite happy to get involved, and I managed to gather a collection of email addresses so that we can either send written orders over to them directly that way, or we can actually direct patients to them for different things that they can be supplied with.
the network of practices working in the way that Q's works has really embedded inter-practice relationships and working together as a team, as an optical profession, rather than individual silos. And obviously the other impact of Q's is the accessibility of patients to urgent eye care, and the also with referral is then required to the hospital eye service, ensuring that the patient goes to the right place first time, and with the transfer of OCTs, enabling one-stop care for people with wet AMD, or even feedback to that actually referral and treatment's not appropriate for that patient, and saving a hospital appointment. So all in all, we've found the service has been really successful in a number of ways, both the hospital, the patients and community optometry.
One thing I'm particularly excited about is the advice and guidance facility. So I think that's a real thing for the future, where there are many occasions in practice you're not exactly sure how to handle something. Do you refer it? Do you hold on to it? And I think the ability to transfer a file with some case notes to a colleague in the hospital eye service, and then to get back to you with it, I think you should do this. I think that will help our optometry colleagues immensely in the future.
When, in March, the COVID crisis hit, our local eye unit were fortunate to have the foresight to share their resilience plan and provide FP10s for our IP optometrists. When LOCSU published the Q's model in April, it captured and brought together a number of best practices from around the country. It recognised the investment and the value of independent prescribing and OCT at the practice level. Although we have care navigation pathways in Herefordshire, we do need to do more to publicise the service so we can further educate the public, the GPs and the pharmacy to streamline and appropriately direct people to services. Our local eye unit has even taken an approach of calling all the local practices each day to identify their Q's capacity.
So can I just thank all the practitioners that sent in their little selfie videos, stepped out of their comfort zones and sent me a little video about what Q's means to them. I think you delivered it much better than I can. So let's keep on Q's for a while. Let's think about why did we need it? Why did it come about? So it was following some conversations and some meetings that I was involved in as LOCSU, alongside Richard Whittington, with NHS England and the sector bodies. And when the COVID-19 pandemic struck, we're all, in alignment that optical practices should be able to deliver essential GOS services, but also urgent and emergency care. Ultimately, we needed to make sure that there was a local provision, that people could receive their urgent eye care closer to home, so that we would reduce their need to travel and ultimately reduce the risk of the infection spreading. And it made sense to me that every optical practice that wanted to participate was able to do so. And we accept, admittedly, that there was limited access to PPE in the early days, but it has with time sorted itself out. And it was really important that every optical practice and every practitioner that wanted to support their local population were able to do so. So Q's came about to really fill the gaps. What we were aware of is that in some areas where they already had a minor eye condition service in place, then those practices were actually able to straight away deliver some urgent care to their populations. But we had huge gaps where people wouldn't be able to deliver the urgent care. So that's what Q's was intended to do. And I think this map provides a really good visual tool. So you'll see that in the dark green areas, we've got established minor eye condition services. In the light green areas, we've got the new Q services, or some of these are minor eye condition services that within the local areas they've adopted the full Q service specification. In the amber areas, we've got ongoing discussions, so there's no service live at the moment, but there's certainly an opportunity for a service in those areas. And then in the reds are the areas where there's no opportunity. at the moment for queues to be commissioned. So let's look at this in a slightly different way. The colours mean exactly the same thing, and we've got two blocks. So on the right-hand side, which was towards the end of October, we've got a lot more green and a lot less red. So more services have been commissioned. So since we published the pathway, 31 CCGs have adapted their minor eye condition service specification to fully meet the specification of queues. And we've also had another 20 CCGs commission queues. So what this actually means is that when we entered our first national lockdown, 62% of CCGs had commissioned some form of urgent eye care vision from optical practice. When we entered the second national lockdown, that had risen to 77%. But what does this actually mean for local populations? Admittedly, on some of these greens, we've marked them green, but in actual 6 CCG areas, it isn't the whole CCG where the queues is commissioned or minor eye conditions is commissioned. It might be just a locality within the CCG, or it was the old CCG boundary. Now the CCGs have merged together. It isn't delivered across the whole boundary just yet. So perhaps a better way of looking at this is to look at the population that's been covered. And as we speak, 75% of the population of England have access to urgent eye care from within optical practice within primary care. So the first bar on your left-hand side is as we entered the first lockdown. The second bar is deliberately as we entered the second national lockdown. So between the first lockdown and the second lockdown, 6.6 million more people have access to urgent eye care locally. That's more than the population of Scotland, and it's twice the population of Wales. And we need to remember that these CCGs that have commissioned in the last few months are actually the same CCGs that have chosen not to commission minor eye conditions in the recent past. So this is not insignificant progress, but is it enough? And we might ask you that in a little while. Before we do, I'm just going to hand over to Tom to talk about a little bit of the queues data.
Thank you. So we got this data from Primary Eye Care Services, who we should thank for providing it. It was pulled on the 29th, so just to show you how good the systems we have in place are now, that we can pull data this quickly, and this quantity is really impressive. And since its inception, there's been over 35,700 patient episodes, which is a lot, and over 3,000 people were deflected at screening. I wanted to highlight this figure. 8.4% of those people didn't actually get a clinical consultation. Why is this important? Well, because they were given advice and guidance and redirected to more redirected to more appropriate care. It's important when we interact with the system as a whole that we show we're able to manage care navigation, that we can take on those patients that are appropriate for our services, but we can also redirect when necessary, because we expect the GPs and the NHS 111, etc., to redirect to us. So we need to redirect to them as appropriate and help with the care navigation issue that the whole system faces. So yeah, 3,000 people were redirected to more appropriate care. Can we go to the next slide, please? And of the 32,260 odd people who had clinical consultations, this is the outcomes. 85% fully managed within the service. The vast majority, in other words, that's 27,000 and a bit people, which is something we should be awfully proud of, I think. That's showing the skills that we have in managing these urgent presentations. Only 8.6% referred urgently into the HES, but referred appropriately with full clinical details and with imaging where relevant. So a real success. So queues is all about seeing the appropriate patients with the appropriate urgency and referring them complete with that clinical data. There are evaluations going on, independent evaluations of this work going on currently that we're aware of. And the early indications are that there is, they are demonstrating a reduction in secondary care activity associated with an increase in primary care activity. So you can see that where the activity is going, and we are supporting the system by seeing people in queues. There's also evidence that the case mix in acute eye care services is changing. So there's fewer benign conditions getting through to hospital departments. They're being seen in primary care, in other words, where they should be seen. So this is being done in a hospital department that is proactive and engaging with the service, but it shows what can be done. Sorry, I lost my train of thought there. So we're moving on to another poll now, Zoe. It's a simple one this time. As Zoe's shown, we've got queues across much of England now, but about a quarter of England isn't covered. Stubborn ones, if you like. You know what I think, you know what Zoe thinks, but what do you guys think? Should queues be universally available across England?
And just while people are just, we're just reaching about 70% there, Tom, but just while people are thinking about this, can I also remind you that the Q&A box, I've seen a few questions popping in, if you want to raise your questions there, that'd be great. Tom, I think we're just approaching about 90%.
I think we can take that as a, it's not going to change that much.
No, I think we'll call it there, because it didn't change very much through all of that, and I think the vast majority of people are aligned with our view that we ought to be looking to get queues commissioned across England. My view is that we ought to have a single national contract, and we haven't managed to achieve that yet, but perhaps that's what we ought to be looking to deliver. Thank you. So moving on, I just wanted to share another film. We've heard from the practitioners that are working within areas where queues has been commissioned, but what's it like to be working in an area where there isn't queues commissioned?
Unfortunately, we don't have any form of commissioned emergency eye care service, and that does distress me quite considerably. We have a demographic of patients who are elderly, immobile, and often live in quite significant poverty. As a consequence, as a practitioner, I spend a lot of time triaging patients over the phone. My optical assistants will deal with them first, and then they'll get passed on to me. And whilst we can offer them a private service, most of them can't afford that. They are an immobile population largely, and unfortunately that often means that they will sit on an eye health problem for too long. I care passionately about inequalities of health in the area in which I work, and I do feel that any form of queues, MECs, would be a perfect fit in the area in which I work.
Over half our practitioners have an OCT. A good handful have the independent prescribing qualification, yet we still don't have a queues. This has led to fragmented care across a whole patch. It's also meant that people don't have access to eye care services, despite this pandemic really showing no signs of slowing down.
Secondary care has encountered its resource challenges, and we are adding to the already stretched services.
Many patients do not wish to go to hospital in the current situation with the pandemic. Patients, therefore, are seeking a more local and familiar place to go to with the right expertise. It is time to put any obstacles to one side so that we can all collectively achieve a higher good, not just for today, but for generations to follow.
So once again, I'd like to reach out to all those practitioners and thank you very much for providing us with your thoughts. I appreciate that one of those videos was very crackly, a lot of background noise, but I really felt that it delivered a message that needed voicing. So thank you to everybody for providing them. So moving on now, we're going to look a little bit to the future and to the National Outpatient Transformation Programme. So the first session of this year's National Optical Conference actually covered the National Outpatient Transformation Programme in some detail. The presentation slides are already available on the LOCSU website, and we'll be making a recording available in the coming days. And so I'm not going to cover that information again in any great detail. I'll try and keep it brief. The National Outpatient Transformation Programme is a national programme of work which started in April and will run for 4 years. Within this programme, there is an eye health work stream. This programme is tasked with the delivery of the NHS long-term plan aims. And so it's no wonder that ophthalmology and eye care has become a priority area for them already, and they've already started work on this area at pace. Since July, and that's when LOCSU became more closely involved in the programme of work, the focus has really been on the restoration of eye care pathways rather than transformation. And there's been the development of 5 integrated care pathways for restoration. But the programme will be moving on to transformation through the coming year. It's important to say that, you know, within the programme of work, we are very much working in partnership. It's about working with the existing resources, using the tools that are already available to us and building upon them. The programme brings together a number of key stakeholders and aims to deliver a united voice for radical eye care transformation across England. So it should be no surprise to us that the programme clinical leads have identified cataract, medical retina and glaucoma as the clinical areas that they want to focus on for the eye care restoration. Now, I'm not expecting you to be able to read the detail of these slides. I think what's the important message is that we've got 3 clinical areas and 5 clinical care pathways that are going to support eye care restoration. So why cataract, medical retina and glaucoma? Well, obviously they're the high volume clinical areas, and between them will account for about 70% of all outpatient ophthalmology activity. So it's no surprise that for the national programme that they're starting with these clinical areas. It shouldn't surprise you that these pathways will be vaguely familiar to you either. They're very familiar to our existing LOCSU pathways. And indeed, they build on what we've been developing for over the last 10 years or so. So the LOCSU pathways, as you know, build on the development of work from local service innovation. We pool together that local experience, what works well within optical practice, and we reflect it back in a national standardised pathway for all LOCs to benefit. Our LOCSU pathways and clinical management guidelines are still very relevant and essentially explain how the National Outpatient Transformation Restoration pathways can be delivered in primary care optical practice. We need to also remember that these restoration pathways are not supposed to disrupt existing services where they're working well. But we also need to remember that there's always room at a local level for further innovation and improvement. And as with the CUES pathway, the restoration pathways invite much more joined up care. They better recognise the capability in optical practice, optimising that first contact care and referral filtering opportunities, and support care closer to home for those with long-term conditions that need regular monitoring. If we look at the cataract as an example, the National Outpatient Transformation Clinical Team believe that if this pathway is commissioned across the whole of England, we'll see about a 20% reduction in referral activity through cataract alone. And they also believe that close to 85% of people that have had cataract surgery could have their follow-up care in primary care optical practice. Thinking about the glaucoma pathway, similarly, if commissioned across England, we're looking to achieve a 30% reduction in referral activity. And approximately 50% of patients with glaucoma could be fully managed in primary care or in the community and have their care delivered closer to home. I could probably talk all day about these clinical pathways, but I'm not going to discuss the detail. They are available to you if you go through and register on the NHS Future platform and access the iCare Hub. And there are joining instructions on our website. We are also hoping to be able to host these within the members area of the LOCSU website going forward. So it provides a little bit easier access to these really helpful resources to LOCs and practitioners out in primary care. I think I wanted to say one more thing about pathways. Although we're having a pathway session and we're talking about individual care pathways, I really want to invite you to think about it in terms of a single service, a single offer. What is our offer from primary care back to the system? The pathways are essentially the detailed component parts, but we need to be seeking a single framework agreement. And essentially at a local level, the pathways can be switched on or off as needed based on population need. I want to move on now to invite a much more some engagement from you all. I'm hoping you've all submitted your questions into the Q&A box, and I'm going to invite panel members to now share their screens and unmute themselves.
Just while they're doing that, Zoe, can I just mention a bit of an advert for the optical lead team? If you're trying to get onto NHS Futures and the iCare Hub that you were mentioning there, when you first join it, it can be really difficult to navigate your way through to those pathways. So if you're having trouble, just contact your optical lead, because we've had this in my area, trying to navigate through and find them all. Sorry.
I think that's a really good tip, and there's so much information on that platform that it's sometimes actually very difficult to find the information that you're looking for. So if you go into the specialties and then go down to iCare Hub, then most of the information can be found there. But like I say, we'll try and see if we can host the relevant documents within our own members area. Okay, so thank you to our team members for joining us. Richard Rawlinson, would you like to introduce yourself?
Good evening, everybody, and thank you for joining this evening. Those of you who are on live and those of you who will be watching on catch-up. So remember, please do not vote if you are not watching it live. Just like to say hi, I'm Richard. I'm an optical lead covering the West Midlands, London, and East of England, and Kent and Medway. I'd also like to introduce other panelists this evening. Max Halford.
Yeah, thanks, Richard. Yeah, hi, Max Halford. I'm one of the LOCSU optical leads. I cover the southwest and southeast along with some of my colleagues, and I'm also clinical lead for Abdo. Yeah, it's really great to see all these people on here tonight, and good to see all the questions coming through. And I'd like to pass over to Richard.
Hi everybody, Richard Whittington, Chief Exec of LOCSU. Those that have been on these sessions for the last few nights have probably seen more than enough of me already. But yeah, really good. I hope we get some really good engagement, and I've too been watching the questions come in. So Richard, I guess it's over to you.
Thanks, Richard. So I think we're going to put these out as they come along, and I think we've got lots of good questions coming in. So, but please fire in more, because we're flipping backwards and forwards across the session. I'd like this to be a round robin conversation. Everyone has a say, and we can only do that with your help. This is your part of the session this evening, so please feel to ask some questions, and questions rather than statements helps me able to look at those and be able to bring those onto the panel. So my first question, actually, and I'll go at the beginning, and I'll start at the very beginning. And the first pathway talks about healthy living optician, or healthy living optical practice. Just like to know the thoughts on how all members of teams get involved in that, and how that's going to, how do you see that being delivered in optical practice? And I'll start with Zoe.
Thank you, Richard. So actually, that's a really good question, isn't it? Because the healthy living optical practice is about the whole optical practice workforce, the whole team. The brief interventions might be part of the site test, but it might be a conversation that your dispensing optician has with an individual during the dispensing. What we've got to remember is that patients are in our chairs for a long time in primary care. we have long appointments, half an hour in the clinical room and very often longer than that in the dispensing area. So we've got plenty of opportunity to have these conversations. What do you think, Max?
Yeah, I mean, I would totally agree. What's great about the kind of healthy living optical practices kind of concept is how it actually genuinely does bring the whole of the team together. You do have different touch points. We all know this is the patients pass through the practice, and it can be your optical consultants, receptionists who have a fantastic knowledge of their patient bases. The majority of them, you've got your optometrists in the consulting room, or perhaps a slightly more formal where they're taking history and symptoms kind of elements. You've got your guys in pre-screen, and rightly, as you said, you've got your guys doing the dispensing element of it, who have possibly more time with patients out of most people in the practice as well. And realistically, all of those guys have got a range of skills, or could upskill or accredit, or in different way just expand their knowledge bases if they're required to do so, to offer more services within the practice. I think ideas like medicines usage review, smoking cessation, it makes complete sense for patients to have an optical practice as a touch point to kind of get involved in those services.
Tom?
Not a huge amount more to add, but yeah, just really like to agree that I think whilst the whole team should be involved, I actually see it being something that's possibly the bulk of it being done by a dispensing team, or during that side of the process, because it's a very formalized conversation you have in an examination room. I would hope the Optom would support and maybe flag up opportunities to other staff, but it'd be in the less formal conversations that you're having perhaps after our examination, where you actually get those wins. And the healthy living concept asks for there to be a healthy living champion within the practice, and I would see that being someone in a role on the dispensing team rather than being the optometrist in most cases.
I think I was just going to say, I think there's a really wide range. I mean, the great thing about it is the kind of almost like the flexibility of the concept. In actual fact, that in a practice, Tom, say where you work, could be very different than how that's delivered in a practice where I work, but the end result would be exactly the same. And that's really what makes it kind of so attractive.
I think also for me, where I think this service, I'm not going to talk about the delivery of the service, but this is the one type of service that, if we look at how primary care networks are likely to evolve, and obviously they have got some evolution to go through, the healthy living optical practice is that touch point setup, the way it's established. It means actually it does tie in to maybe other pathways we're not normally involved in, things like frailty pathways, falls pathways, all this kind of stuff, where you might see a patient and think, they could be at risk of something else. It does actually allow that tie-in to take place. So it's ironic, really. It's one of those ones that, from a commissioning perspective, hasn't been that easy to get everybody interested in. But as the networks start to evolve, I wonder whether or not it might actually be the one that starts to tie in optical practice into the broader primary care network.
I even had a conversation this week about signposting dental issues from optical practice, believe it or not.
I can see that kind, maybe not dental issues, but I can see that kind of thing happening.
Thank you. So we've got lots of questions coming in about challenges, and the challenge of actually being able to participate and deliver these pathways across the country. Very much that covers actually all of the pathways we've talked about tonight. Have been brought up by many of the people asking questions. I suppose to bring those together, I just want an interest, what challenges, or what do you think we can do to support areas that don't have these services in the first place, and how they can be supported to get them in place? Because that seems to be a common theme coming up, of areas that have the areas in red on this chart that can't get services or haven't got them. How can we support that as a whole? Max?
I would say it's about sharing best practice. I mean, I've got within the areas that I support for LOGSU, I have got areas which have got great services, but then again, I have got areas where, they are really, really struggling to embed those services, or to move from MECs in part of the areas to a queues across a whole of a CCG area. I mean, it is a matter of trying to explain and share the story of where it's been a big success in an area, and try and show the commissioners, my feeling very much now, it's past the tipping point. If you are in an area where there isn't queues commissioned, or in an area where they haven't adopted the mix, or there is no service, you really are an absolute outlier now. And that's the kind of conversation, I think that's the way the conversations need to go, is to say, look, you really need to go back and revisit your decision that you perhaps made back in April or May to not do anything, because you're standing there very almost alone in the fact that that you haven't done something, and the very vast majority of people have. Zoe, I don't know. I mean, that's how I would try and explain it to the CCG and support the LOC with that kind of conversation.
Absolutely, and I agree with everything you said there, because I think there's a lot to be said around local case studies and sharing the data and sharing the evidence base. And certainly I know that from the queues work that's been going on, the early adopters, there's going to be some case studies regarding that, and Tom touched on that in his presentation today. But we've got to remember that we're in a different place now as well. We've got this national programme of work, we've got all the stakeholders on that programme who are aligned in their clinical view. And the direction is for primary care to do a lot more of the care in optical practice, to provide care closer to home. And our hospital teams need us to support them more. So I certainly, from when I go around the country and I'm talking to local systems, I think there's been a little bit of a change in the last few months, and they're inviting that conversation. So before, we're looking for levers to be able to open the door. I think the door's wide open there now. The challenges perhaps are more around that connectivity piece and the commissioning piece. And I'm going to bring Richard Whittington in to maybe say a few words.
Thought you might. Yeah, I mean, connectivity is definitely an issue, and it's probably something we'll touch on a bit later on. But I think there's an opportunity here. At the moment, we are going through, and we have gone through, a process of CCG merger. That's going to continue to roll forward at least until, well, this wave until April, end of March, April next year, and then you go through a second wave. So we're also, as that merger process takes place, we're also going to start to see not so much the evolution of ICSs, although it probably is an evolution, but we're going to start to see integrated care systems come forward a little bit. Anybody who reads anything in the clinical press will start to see that there's loads of planning work around ICSs. Now, that is not without its risks, but today, as we're talking about extended services, as those ICSs form, and as we see CCGs brought together, either formally in merging or in partnership within an ICS, I think what we're going to start to see is, I doubt there will be when ICSs are fully formed, I doubt there'll be any ICS left in the country that hasn't, within its network, got a CCG commissioning AQs or a MEX type service. I can't say for certain, but I suspect that probably will be the case. When that happens, there will be a debate in the ICS about what you do with these contracts. And it will go one of two ways. It will either be decommission them or spread that contract across the whole of the ICS. What we have to do is make sure that it's always the latter. And that is going to be about working with our commissioners, but it's also going to be about us working in partnership. We're going to find a situation where LOCs, particularly, that maybe aren't necessarily used to working with one another, even though they may be next door, are suddenly going to be brought together to work within an ICS patch or within a regional patch. And I think what we need to do is really exploit those opportunities. So as we start to move forward in this kind of slightly different commissioning structure, as Zoe's already talked about, we have the transformation project, which I think acts as an impetus, but we've got to start talking about consistency. We've got to talk about single approaches. We've got to start, connectivity becomes vital. Where I think we slightly undermine ourselves is when, if we take queues as a case study, we went through, albeit very rapidly, a process of getting that specification signed off by both colleges. We tried to engage NHS England to do it nationally, and actually, in fairness to some people in NHS England, they weren't actually adverse to it, but there were a lot of hurdles to get over. But what we've seen in some places is having got that consistent specification, having got that consistent sign-off, it's then been changed locally. I can understand why that happens, but actually that slightly undermines our position. We need to be consistent. We need to work together. We need to try to do things as much as possible in the same way. And if we can do that, I think the mergers and the ICS formation presents an opportunity for extended services. That does not negate some of the risks elsewhere, which we won't, not necessarily for tonight, but I do think there's an opportunity.
Thanks, Richard. So bearing that in mind, just a quick question, hot off the press, is that whilst we've just talked about things getting bigger and consolidation, someone's asked the question of should we as LOCs be engaging with primary care networks?
I'll go for that one. Yeah, actually, I mean, admittedly, some primary care networks are an interesting one in that I think probably actually at the NOC last year, primary care networks probably had a higher profile than they've got now. Primary care networks have been kind of absorbed in this whole kind of ICS type evolution process. And to some extent, they've kind of been knocked slightly off course by COVID, because had primary care networks been in place 2 years previously, you'd have seen them absolutely flourish under COVID, because it's very clearly that would be the process to get lots and lots of different sectors working at the same time, but they weren't quite mature enough, I don't think, at that point. But where you have primary care networks active, and they are active all across the country, and we can get access to the people leading those primary care networks, absolutely. And it might be no more to start with that just as an LOC, introducing yourself to the local leaders and saying, this is what we do. In other areas, primary care networks may be more involved and maybe doing more stuff. But yes, absolutely, we should be trying to do that. And I think from a LOCSU perspective and from a support perspective, it's sometimes difficult at a very local level when you're sitting at a national level to understand who the local leaders are, but we need to try and tap into this. And that's something that LOCs can really do effectively, because you know who your local leaders are. Max, I mean, I guess Devon's classic, because you're sharing an office with LMC colleagues and LPC colleagues. I mean, have you got anything to add to that?
Yeah, I mean, I think we are hugely advantaged by the fact that it is really a matter of walking upstairs and you're in the same office, or you were pre-COVID as the LMC, and we sit alongside the LPC. So primary care networks, I mean, you do feel slightly disadvantaged in their conversations with them are probably more advanced than the LOC conversations with these guys. But the personality, it's those personal kind of relationships, and it's knowing who the personnel are within those organizations has been hugely helpful to us. I think we've always been aware that we have to engage with everyone. That's the whole kind of idea. We've always reached out. We've always tried to engage down in Devon with these different sectors, and I'm hoping, I think, for the area that work that we've done previously, that kind of networking work that we've done, will pay off in the future, because I do see primary care networks with the delivery of COVID vaccination, etc., are going to become more of a feature and are going to become more important. And if they are going to be more important, we need to have those big relationships with them.
Excellent, that's really good. I've got some more Q's questions. There's lots of Q's questions coming in, so I'm going to try and bring some of those together because lots of them are very similar. I've got a great one here which asks about, should Q's be included in a package? Namely, should we have cataract, pre and post, glaucoma, and OHT monitoring, all of those things put into single packages? Is that a way in which we can go to and enhance our possibility of getting services?
So I'll take that one. It's simple, yes. When we're talking about a package, we're talking about the whole primary care offer to the system. So absolutely, it's part of the package. So the National Outpatient Transformation Restoration Pathways, the way if you read the information that's sitting alongside them, the roadmap, they very much see them sitting alongside and working with Qs. So they're absolutely promoting the continuation of Qs for the longer term. as the urgent eye care pathway in primary care. So whilst the name suggests that CUES was developed as a COVID-19 response, and it was, and it provides care closer to home. But one of the aims of the long-term plan is to provide care closer to home, isn't it? So it describes how we're delivering urgent eye care close to the patient's home. So it's absolutely fit for the future in that way, and it ought to be part of that wider offer, without doubt. Anybody else?
Well, I was just going to say, it never, it doesn't really make sense not to put them all together in a package, because if your concept is that you agree that, for example, CUES reduces a burden on secondary care, then you've got to kind of argue that everything else doesn't. And we all know that everything else absolutely will help and support and keep patients closer to home, all the things that we've talked about for years and years and years. So it just doesn't really make sense to try and deliver those things piecemeal, because they work better as a whole package of care.
I think there's currently a lot of opportunity here, isn't there? Because the National Outpatient Transformation Programme stuff is all coming together at once as well. So here's a block of work that we recommend you do. Put it all together to get all the benefit out of it. Why would you take a piece out?
Actually, I was just going to ask a question. I was going to ask Richard a question there, and Tom's just reminded me, because on the very first webinar we did of this NOC, where we had the two colleagues on from NHS England, and they were really supportive, weren't they? They were really supportive of extended services in the community using the National Outpatient Transformation Plan. And I was just going to say, Richard, does it depend a lot on NHS England and the support that they're giving to LOCs locally and regionally, which drives the success of things? And I'm particularly thinking about when CUES was instigated, and some NHS England regions were really behind it, where perhaps others drifted away a little bit.
It can do. I mean, the local success of any particular service is down to the local practitioner and how well they engage and how well they deliver it. And I think that will never change. There is no doubt that where an NHS England, we have to remember how this is commissioned. I think it's important just to stress this. NHS England, when we talk about extended services, so CUES as in this example, NHS England are not the commissioner. The CCGs are the commissioner. So NHS England can obviously influence. NHS England they can't necessarily exert pressure. I mean, they can try to, but they can, and I've been on the receiving end of that, but they can exert pressure on CCGs. But ultimately, the decision as it stands at the moment is down to CCGs. Certainly, if NHS England are saying it is a good idea, CCGs should listen. And I think the outpatient transformation project is more likely to generate that kind of reaction in the CCG. So if the outpatient transformation project is saying this is a good idea, I think CCGs will move. Having said all of that, if it was that simple, we wouldn't be having this discussion. There are still always local considerations, whether or not that's local acute contracts, whether or not that's community-based services, or those kind of services that sit between primary care and hospital care, whether or not they're in existence already. Some areas have got a multitude of different providers all doing different things in kind of the same way. That always complicates things, but there's no doubt, I think, that if we can have a strong central message going out to the local commissioners to say that you should be considering doing this, that isn't a hindrance. But all that does is open the door. We still need at a local level to be strong. We need to be making the case. And obviously at this point, LOCs understand that area better than anybody else and can flag up any particular local nuances that may or may not make that more difficult.
I can just back up with some examples from the Northwest, to be honest, because we had really strong NHS England support, which was very useful. We still have a couple of red splodges on that map, which are a shame. And that's just because of local circumstances. And if we go back a couple of questions asking about areas with no services, what can they do? Well, I just want to acknowledge the frustration that can be felt by some LOCs in those circumstances, because I've got a couple in my area where they've spoken to everyone, they've tried their best, they've taking whatever opportunities came their way and still not managed to get anywhere. And I just want to acknowledge the frustration that some people feel with that. As Richard said, the opportunities are coming because of the changes that are coming, but it doesn't always work.
Thanks, Tom. And also looking to the future, and there's quite a lot of questions coming up this evening about the future. We've talked about future pathways which we could look at investing time and expertise at looking. But also questions coming in about the future of how you see current wave of services that we're providing developing, especially with regards possibly to queues, and how the panelists see that changing, if at all, over the next 12 months, and where we're coming from and where we're going to. And there's a lot of people asking that question because obviously with the COVID name, how does that feel we're going to develop that? So just interested in the panel's view on that.
I'll start this one again and bring other people in as we go along. So absolutely, queues was written at a time where optical practices were just delivering essential and urgent and emergency care. So they had a huge amount of capacity to deliver to this service. And one of the things that was stipulated in the service specification was that a very prompt response to a patient when they presented to the service for the remote consultation. And that has been a challenge for optical practices since they've opened their doors back up to routine care. We recognise that. And all service specifications need to develop and evolve. And what we need to be doing now is working alongside the early adopters of queues and the National Outpatient Transformation Programme to evaluate how successful queues has been at a local level, and also look at service improvements. Queues was developed, yes, on the back of a considerable amount of experience and feedback. From even if you look back, as Tom and I did, to the NOC session last year, you can see elements of the queues pathway that came out of that session and our conversations there. So it was 3 weeks in the writing, but years in the making. We took that opportunity. Queues also has an awful lot of ambition still within it that I don't think any system is fully being able to develop yet and to deliver yet. So there's a lot for local systems to continue to evolve and deliver the advice and guidance element, the remote prescribing element. I know some systems are still on paper in the contract, they're able to make full use of their independent prescribing practitioners, but the independent prescribing practitioner hasn't got their FP10 pad yet. That sort of thing still needs to catch up. But there's always room for improvement, but we need to work with the local systems that have been early adopters of queues and evaluate it to understand where to move next, and do it once. We need to do it. This is a national service specification. So we need to work with those local systems and then bring that information together centrally to change that service specification once.
Can I just come in on that? I mean, yeah, I agree with all of that. And I certainly agree with this. This is a national specification, do it once. I think the other thing that is interesting, actually, and I was struck with this actually watching the first video. I don't think a year ago, certainly 2 years ago, but a year ago, I don't think we routinely used the word system. I think we talked about services, but I don't think we talked about systems. And to be honest, I don't think the NHS did a lot. And I think for me, that is where, not necessarily where queues, I mean, it is a bit where queues evolves into, but it's where everything evolves into. One of the people on the video, I should have got the name, I was watching it, I didn't scribble it down. One of the people on the video made a really key point, which was that since queues have been commissioned, it allowed practices to work together within a system. And it's that working together within a system that I think is where this opportunity lies. I think previously we've talked about MEX providers or cataract service providers as though they were this kind of oasis in the desert, and there's a couple of them here and a couple of them there. We have to think of the delivery, we have to think of how services evolve in the future, have to be systemized. It's not about one practice being in competition with another practice or one area being in competition with another area. It's about working together with the patient at the absolute center. So it may be, as things evolve, that in some areas, maybe there are some practices that do one bit and there are other practices that do other bits. I don't quite know how it will evolve, but it has to be about this system. We kind of need to move away from this very siloed view and move towards a system view. And if we can do that, then I think we do then see the genuine evolution of extended services, and we start to see what they could become.
I think the other thing is obviously is the fact that we were actually getting the data out, and we're getting the data in good volume, which is proving the case. And again, from Tom's slides earlier on in the presentation, what was it, Tom? 0.8%, I think, deflections with advice and guidance from patients, coming into practice or contacting practices. It speaks for itself, doesn't it?
Yeah, well, somebody actually picked that up in a question. I noticed it, 0.6% it was, and I really meant to mention it when I skipped over it by mistake. Yeah, we need to really enhance that advice and guidance element. It's key to becoming, again, part of the system.
And I suppose with my dispensing optician hat on, there's a real role for these guys to be playing in that as the front line in the practices, giving that advice and guidance as well. And they are going to be the guys that are going to be accounting for, I imagine, a significant chunk of that advice and guidance going out there. So again, it's kind of involving the whole, the whole range of practitioners within practice, which is what makes it so, as a concept, as cues, makes it so appealing.
Thank you, Max. That's helpful. That answers the question just came in about dispensing opticians and their involvement. Is there anything else you want to add to that with regards to the involvement of dispensing opticians with our pathways and more of a general collaborative working amongst all of our healthcare professionals?
Yeah,
the panel.
I mean, if I can pick up and I'll get my bit in first. But we've obviously got, we have got the extended services qualifications for contact lens opticians, which we run. It has been, unfortunately, trying to get them through the accreditation process has been a little bit more challenging because of COVID. But we do have a cohort of guys out there who are working within Qs and MECs delivering services. We've got everyone who's stepped up and they're working at the full extent of their competencies as well. I mean, we spend, within LOCSU, we do spend a lot of time looking at pathways and making sure that they are inclusive wherever possible. And that's what's really healthy about it. But also, we do look at those pathways, and I certainly, with my Abdo hat on, look at them and think, well, do you know what? There's an opportunity. That's something that we might not be able to do now, but do you know what? There's nothing to stop us with some accreditation, with some courses, whatever it may well be, getting involved in those delivery of those services in the future. So it's a two-way street, really. It's kind of like saying, this is what we can do at the moment, and LOCSU does recognise it and is inclusive to it, but it's also as a group of professionals thinking, actually, it's not going to take much of a difference for us to change, perhaps expand our scope of practice a little bit, and then we can get even more involved. So it's really refreshing kind of place to be, really. As a DO, I think at the moment there's a lot of opportunities out there for the future. And that's my advert over, my little bit for a couple of minutes.
Thank you, Max. We've got other questions coming in about inequality as well, and I think that's a general theme that's coming through lots of the questions about areas without. Someone's mentioned, and I love the term stubborn commissioners, and I think that's quite true, that some of us are it is by no means lack of trying and skill and worth of LOCs that some commissioners will not develop these services. What's LOCSU going to do about it? Clearly, that was one of the questions. I would probably rephrase that. What will LOCSU and the LOCs do about it? But I think it's an important question, because I think inequality will get greater as we start to look at the future of our services.
So I'll start with that, because actually I used to be one of those stubborn commissioners. I really was stubborn as well. So the question, just to clarify, are we talking here about what are we going to do about equality issues, or what are we going to do about stubborn commissioners? Because they're two slightly different things.
Yeah, I think the general flavour here is that the areas that have services are butting up against areas that don't have services. Therefore, patients there's an inequality of access to services across the board in some areas. And that only highlights it when you've got a suite of services in one area and someone else has only got an eye test. So
it becomes a lever in itself, doesn't it?
Well, that's exactly what I was going to say. It does become a lever in itself. And I think actually one of the previous answers about how emergency CCGs and ICS is developing may start to slightly help with that. It does become a lever. I think where we are though is, and we started to see it a little bit in Zoe's presentation, as we've now got more areas that are commissioning a service like this than do not, we've got a body of evidence and we've got a body of data that we can start to look at to say, actually, what is the genuine output from these services? And we're very good. I think the NHS, generally speaking, is very good at measuring. It kind of measures activity, but it doesn't necessarily measure output, and that's long been a criticism. We need to kind of move beyond that. If we can move beyond activity data is useful. It shows how many people are accessing the services, and when that to some extent feeds into how a lot of them are paid for. But I think there's a bit of work to do with the data to really push at the outcomes and to understand what these services mean for patients. And I think if we can do that, and as LOCSU, if we can do that using the data that we've got, that allows us to present a different story to the stubborn commissioners. It's not the historic one about saying we can reduce activity, we can save this amount of money, we can save that amount of money, because I think that's a bit old hat. It's more about saying these are the clinical outcomes and the clinical experiences we can give to your patients. And I think as we move towards a different type of commissioning regime, and probably arguably a slightly different NHS, that will have more leverage than maybe the arguments we've used previously. So that's a bit of work that we have to do, and that I can commit as long as we can. We'll work in coordination with the primary eye care companies, and that's all primary eye care companies, to start to understand exactly what that looks like.
Thank you, that's great. And on the subject of data, other people have raised a couple of information of how best can we collate the data across the whole of England to support the services that we currently have and develop more services moving forward. And I just wondered, from the questions that are being asked, how all LOCs can feed in and support that. Any ideas as to how best we could do that? Zoe?
Well, certainly the National Outpatient Transformation Team were inviting people to get involved, weren't they, in the share their data. So that we would be working alongside them to share case studies and promote that through the NHS Future platform, the Eye Care Hub, and the Future NHS platform, sorry. So that's one route, but certainly we'll work with any local system that has commissioned any of these extended primary care services and pull that data, work with them to better understand those outcomes. As you know, already we're working with the primary eye care companies who routinely share their data with LOCSU, and we'll be able to use that data, provide it to the National Outpatient Transformation Team as well, and that will be used to further inform the development of these care pathways. And the radical transformation that we're going to start next year.
I will just add, it's really interesting to see, because I'm in areas where we've got pairs, and then I also work across areas where we've got other primary eye care companies. But actually, when you look at the data, the results are so similar. It's quite interesting that although the approaches may be slightly different, and the pathways may all have their own slight what should I say, the twist on the way that things are actually delivered within practice, the outcome data is very, very consistent across it, and it all shows that where these pathways and where these episodes of care are in place and people have been looked at and cared for in the practices, it is actually making a significant difference to the outcomes.
Brilliant. I've got a couple of questions on connectivity and how the panel see that developing in the future to support our services? Well, it could be an hour's question, couldn't it? But
I think we'll look back in a few years' time and wonder how we managed without. Put it that way.
Yeah,
it's coming, and there's a lot of development work still needed. But my gosh, it's going to make a difference getting some connectivity.
Right, and
Richard, if I can just come in on that a bit. Yes, it is coming. There is an awful lot of discussion going on at the moment around connectivity, and people may or may not be aware that there's very recently been a DPS, which is a dynamic procurement system piece around connectivity, launched. We'll talk to different LOCs about this as and when we fully understand it, but there is a shift in terms of connectivity. The Outpatient Transformation Project certainly recognises that connectivity has always been seen as this enabler. It is the enabler, and I think there is an understanding of that now. However, again, it goes back to my previous answer. If it was as simple as slapping a solution and doing it, it would have been done already. It's not. It's very complicated, and there are risks inherent in any kind of fully encompassing connectivity system, which you can be assured everybody, all representatives, all steering group representatives on the outpatient transformation work are aware of and are keeping in mind. So sometimes it can be really frustrating because it looks like this should be something really simple. And in one respect it is, but in another respect it is not. And what we're having to do at the moment is kind of balance simplicity versus the complexity and making sure that nothing gets put in place or nothing happens that, for all the right intentions, moves us backwards.
So a little bit of question of watch this space and work again together to get that through. Question coming as well. Hopes and fears. So what do you hope for in the future of all of these pathways? Where do you see it going? We sit here and we work on a yearly basis, but a couple of questions about where are we going with this? Where's it all going to end up? We don't know, I know, but what's your thoughts?
Well, I'll start on that one a little bit, because we've got, we had our wish list, didn't we? We spent a lot of time at the NOC last year, and we got a long list of that real blue sky thinking. And what came out of that for me was there's so much more that we can do in optical practice that we can offer back to that system. But by no means are we doing it all now. But since we had those conversations and we have got COVID-19 and the backlogs that hospitalised services are facing now, the real opportunity is to be working with our secondary care colleagues and to work with them to address these to restore these services. Let's get back onto a better footing, and we're going to be doing that, working together. So in a couple of years' time, I would like to think that we don't have the backlogs, we don't have the long waiting lists. We have a much more joined up provision across the country.
I would say I would totally agree with everything Zoe has said there. I mean, what would be just fantastic is consistency. I mean, it never fails to baffle me how a post-cataract appointment in one part of the country is completely different to a post-cataract appointment in another part of the country. You know, there'll be 5 different versions of the same type of service looking at delivering the same outcome, and it just makes no sense. This continued wish to reinvent the wheel makes no sense. So I suppose my wish for the future is that people realise that there's a set of pathways out there, the data's there to show that they work well. Stop trying to reinvent the wheel. Just go and deliver what's out there.
There you go. So that's probably a great point just to stop there and say don't reinvent the wheel and get on with it. So we've got some closing remarks. So we're going to go for some closing remarks and just to say that we've had lots and lots of questions, lots and lots of statements on there. If you want anything you want to feed into the team, we'll have a look at this. We can do some replies, and obviously your optical leads are there to support you, and you can ask questions whenever you wish. So let's hand over to Zoe and we'll pass down. So any closing remarks, Zoe?
Thank you, Richard. Well, I've not got any closing remarks, but I'm going to hand straight on to Richard Whittington, who's going to close the session with his final thoughts.
Yeah, thanks, Zoe. Kind of feel like I haven't got many now because I had written down some things I was going to say at the end of this session, but we've covered them all in the questions, which is actually really good. I think that's a much more useful use of time. So I think really I'm going to end with what I was going to say as my final point in my other comments, which is we do have an opportunity. It's really difficult to see the opportunities at the moment because COVID is the curveball that no one expected. It's been really, really difficult. And I think in all the sessions that I've started so far, I've said that we have to be really proud of our response to COVID, but we also have to remember it has taken a toll on people, both professionally and personally. And I'm always very mindful of that. But through this, an opportunity has emerged because I think everybody's recognized that COVID has challenged the system like nothing else. And the system being the whole system, not just primary care, but hospitals as well. The system has just about survived, but only because we've stuck loads of plasters over it and lots of stuff didn't happen and lots of stuff was cancelled. So it's challenged the system and it gives us an opportunity. But I think we're only going to maximise that opportunity if we firstly work together. We always talk about this at the NOC and we always have debates and we're all fully aware that there are divergences of opinion and there are differences of opinion in different areas and between different LOCs. And that's a good thing. Debate is great, but there's much more that binds us together than there is to disagree with. So we must work together. We must work together across regions and certainly across a broader footprints than we do now. And that we started that through the regional forums, and I hope we can kind of continue that work because it's that's going to drive this forward. We've got to try and stop differences from stopping progress. The differences are tiny and they get magnified. But I think if we can come up with a consistent approach, working together, trying to do things in not homogenized way, but in a similar way, and absolutely placing the patient at the center of everything we do, which we do anyway, but be really, really explicit about that. I think there is an opportunity here to fundamentally change what extended services do. And that's something that LOCSU will support completely, both through the work we do nationally, but also through the work of the optical lead team, 3 of which are, well, 4 if you include Zoe, are sat here. So my final comment is to engage with the process, really be aware of what's going on, engage with the forums, engage locally, make use of the optical lead team, make use of us, and we will support anything we can do to drive this forward on a consistent level. My thanks to everybody who has asked questions, who produced videos. There's been lots of activity on Twitter about your LOC campaign. All of that is brilliant. It's all about raising the profile. So my personal thanks for that. And finally, thank you again to Optus for sponsoring this. I think I've said on previous sessions, sponsoring a virtual conference is not an easy thing to do. So I thank them and it's very much appreciated.